Good afternoon, everybody. I'll be talking on sutureless scleral fixated IOLs. So the scenario is on table, we have no capsular support without any complication. So we have two options, either to intervene in the same sitting or we can have a interval surgery. Just for the sake of the better visual outcome, suppose there is no compulsion, no commitment, no promise, no hurt ego, then a option of stage surgery is still viable. Why? Because after a period of 3 to 4 weeks, if we leave the case by clearing the anterior chamber with the vitreous and we leave the case, we may get a very good capsular support in form of a fibrosed capsular ring. You see what happens, anterior and posterior capsules, they get fibrosed and maybe a peripheral one, but we get a very tough ring. So that will be adequate to support any type of the rigid lens. Sulcus fixation is always better than scleral fixation. So as far to intervene, we have seen the anterior chamber iris fixated. So I will be dealing with the SFIOL without sutures. This is very easy, effective and inexpensive modality. Before coming to the actual procedure by the video, I would like to consider the vitrectomy. Insufficient posterior capsule without other complications. We need to eliminate the vitreous from the anterior chamber and from the iris. At the same time, a deep anterior vitrectomy is needed. It is desirable, it is imperative, because we don't want the vitreous to come into our affairs. So what the usual mistake we do is doing the vitrectomy with the port for the IOL implantation. That is very disastrous. You know, performing anterior vitrectomy at the atmospheric pressure may lead to certain things. First thing, it will need to increase the vacuum that will in turn pull the vitreous or drag the vitreous. At the same time, it may hurt the iris and the cornea. So the preferable one is through the pars plana. Now, if we have the complications in form of dislocated nucleus or cortical matter or IOL, the first thing is, as usual, the first thing is pars plana vitrectomy, PVD induction, and then the complete vitrectomy, retrieval of the IOL, cortex or the nucleus. And I usually defer the SFIOL for the next sitting, because there is no point in leaving behind a badly insulted and multiple perforated eye, 3 ports for the vitrectomy, 2 sclerotomies for the IOL retrieval, loop retrieval, 2 in the cornea, and there will be a badly insulted and the hypotenuse eye with all attendant complications. Which IOL? We usually use multi-piece foldable or multi-piece rigid. We will cut short the price. Sutureless SFIOL, no flaps, no dissection, no glue. It is inexpensive, no sutures. Sutures have their disadvantage in form of breaking of the sutures, decentration, stability issues. We have a better stability, and moreover, you see, with the method we are using, postoperative decentration can be corrected easily. Now, this is the first video. There is conjunctival peritomy at the 2 and 8 o'clock positions, marking of the incision sites with the help of the instrument. Then we will create partial thickness scleral furrows 1.5 to 2 mm away from the limbus and extend them in anti-clockwise direction for 5 mm into the sclera. I would like to put the AC maintainer, and here through the pars plana, and a deep anterior vitrectomy should be done. So I am doing the vitrectomy of the anterior vitreous. Then this is a rigid type of the IOL, so as section will be like SICS, sclerotomies are formed, then retrieval of the loop through the sclerotomies. Take care while taking out. Now just deposit these IOL loops into the intrascleral tunnels which we have made. At least 3 mm of the distal part should be inside the intrascleral tunnel. suture the peritomy, alternatively you can cauterize it and reposit it also. Now the second case, at 2 and 8 o'clock peritomy, cauterization, marking it, then creation of the, with lens tip, partial thickness furrows, extend them 5 mm with the help of 23 gauge MVR in the anti-clockwise direction. AC maintainer is always better than the pars plana infusion cannula. Retrieve the loops through the sclerotomies. At this juncture, it is tilting. The sclerotomy, the furrow, partial thickness furrow should not be more than 2 mm in the length. And at least 3 mm of the distal end should be deposited into the intrascleral tunnel. Now, postoperative care, centration of, check the centration, visual acuity, intraocular pressure, look for the haptic exposure, and few things to be considered later on at the test, at the same time. Be ready for the intraoperative modification of plan. You may have broken loops, you may sink the IOL. Always assure positive pressure. AC maintainer, I like AC maintainer in place of pars plana infusion cannula, because in pars plana infusion, there will be a positive pressure creation gradient will be behind the iris, and every time you will enter the anterior chamber, your iris will come out of the incision. So in AC maintainer, the pressure gradient will be anterior to the iris, and it will keep the anterior chamber inflated. Minimize the surgical time. Proper IOL positioning, as I have already told, that there should be at least 3 mm of the distal part into the intrascleral tunnel. Intraoperative bleed, it's a frequent thing. So for that, maintain the positive pressure and minimum handling through sclerotomies for haptic retrieval, and hold the distal end of the haptic by the tip. You see, if it is beyond the grasping of the tip of your forceps, then it is likely to rub, or it is likely to scratch the ciliary body, and it may cause the bleeding. These are few photographs of the centered IOL, and these are the shine flow images, just to corroborate and document that we have a centered IOL without tilt. Thank you very much.